Hi, everybody, and welcome to the CADIO webinar. It's really great to have you here, and I'm especially happy to be able to introduce Emily Feinberg, who is faculty at the Hassenfeld Child Health Innovation Institute at Brown University and a professor in the Department of Health Services, Policy and Practice at Brown, the Brown University School of Public Health. Emily is trained clinically as a pediatric nurse practitioner, and she continues to see patients on top of everything else she does. She served as core faculty on Boston University's Maternal and Child Health Bureau-funded Maternal Child Center of Excellence, mentoring MPH and DPH students. The impetus for her research has come from the disturbing inequities in access to developmental and mental health services that she's witnessed among the children and families with whom she works. The overarching theme of her research has been the redesign of community-based child health systems. She's applied this lens to a number of public health priorities, including maternal depression screening, management and prevention, autism services, and the integration of child mental health services within pediatric primary care. She leads research that investigates models that engage lay health workers, such as family navigators, family partners, and community health workers, to assure equitable delivery of early diagnostic services to young children with autism and access to behavioral health services more broadly, and serves as co-director of Team Up for Children, a foundation-funded initiative to implement, this got a little garbled, sorry, a foundation-funded initiative for integrated behavioral health and a network of Massachusetts federally qualified health centers. Thank you so much for being here, Emily, and I'm really looking forward to your presentation.
Thank you, and it is my pleasure. So I'm going to talk today about a study that has been going on now for about 4 years, optimizing a paraprofessional family partner navigation model for children. We call it Dot House Cares for Kids, which is the Dot House is the health center where it takes place and also where I work. So I'll tell you, Linda very nicely introduced me, but I wanted to tell you a little bit about the impetus for this study. My work for the last 4 or 5 years has really focused on how you can use lay health workers to address inequities in child developmental services. And for those who are unfamiliar with what a lay health worker is, it's a sort of the broadest term that encompasses community health workers, patient navigators, family partners. I will be using the term family partner in this study, which is what we call the personnel or the staff that have been delivering the intervention for this study. There's been real increased interest in the role of lay health workers for a whole number of reasons, one of which is the mental health crisis among children and youth. But some other reasons or some other factors that really promoted the interest in lay health workers has been the change in healthcare structure with an increase toward more capitated payment. Like in our state, we have a Medicaid waiver that is moving toward a fully capitated system. The workforce shortages, we've had real challenge both with the primary care and the clinical workforce who provides mental health services. And this desire to allow everybody to work at the top of their capacity. And there's also a renewed and very welcome new focus on health inequities and structural racism. And for all of these issues or topics, lay health workers, or we'll call them family partners, are really uniquely positioned to address these kinds of issues in terms of task shifting and also their role as members of the communities which we serve, and their both cultural and linguistic similarities.
Like, can I interrupt you for 1 second? I don't know what you mean by a capitated system.
Oh, sure. So, traditionally things have been fee for service, meaning you do something, you go to the doctor and you get a service and you get reimbursed for that service. what is happening now in most Medicaid plans is something we call, they're often referred to as accountable care organizations. You may remember managed care organizations from way back when. And so these are larger systems where the larger system receives a per member per month basically reimbursement to provide services to a specific population. And it requires a site taking risk, but what it means in terms of, it gives a site a lot more flexibility to really look at the unique needs of a patient population. So they might say, my population really needs to have extra work around housing, let's say, for example. So we're going to actually put some of our funds, and we think it's going to save us money in the long run to provide, maybe some housing, supported housing after discharge for complex patients. And then there may be another site that says our real issue is transportation. We can't get people here. We're going to take some of this fee and use it for transportation. So what we have seen all over the news is about the mental health crisis among children and youth. And these have certainly been exacerbated by the pandemic, but these are rates that started increasing even prior to that. And you can see the graph shows what it looks like for major depression, but you'd see a similar pattern for anxiety and for some neurodevelopmental conditions such as autism. And to me, the most glaring and the major motivation for the study that I'm going to talk about is this is the statistic, and this is from 2019, that roughly half of children who have a mental health condition are not receiving treatment. So the intervention that we used in this study, we refer to as family navigation. And it is a multi-component care management intervention that was specifically designed to reduce access disparities in access to health services. It has its roots in cancer care. Initially, it came out of a desire to provide more equitable mammography screening and follow-up, and then has expanded to a variety of other conditions. In our study, we've expanded the focus from the individual patient to the family, and from the healthcare system to the range of systems that children and youth interact with. So that could be schools, early intervention programs. And there is really strong evidence of the effectiveness of different navigation models. And what this study is really focusing on is, how do you deliver navigation? And so it's a little bit different in that we are not, and I'll go over that more, we're not really manipulating different components of the intervention, but we're really focusing on different delivery strategies. So our preliminary work in this area was actually focused specifically on kids with increased likelihood of autism. And we developed a manualized core intervention that was, it was specific for autism in terms of the number of visits. But the other components in terms of active outreach to families, the individualized context, the cultural concordance, and sort of goals for each specific condition or visit is carried through into this study. And in this clinical trial, it was compared to what we call conventional case management, which was clinic-based, and it only happened if the family initiated the contact. The trial took place in 3 different states in a number of different primary care practices, and we had good evidence of its effectiveness for our 2 primary outcomes, which were the time to diagnostic ascertainment, which is a really key marker for kids with who become diagnosed with autism, because it enables families to access new services, and also for a longer term outcome, it did positively affect time to participation in Part C early intervention services, which are the services which exist nationwide that are authorized under the Individuals for Disabilities Act. So again, we felt pretty good about the content of the intervention, but we really were not clear on what was the best way to approach delivery. We had an incredible opportunity. It was very timely, and that this NIMH issued a funding opportunity announcement in 2017. And it was as if it was written for our work. And it was looking at they called it a family mental health model to promote early access, engagement, and coordination of needed mental health services for children and adolescents. And they were interested not only in the actual services, sort of types of therapy, but really also in the coordination of mental health services and the idea of trying to titrate services to changes in child's condition. And they were also interested in use of new technologies. So based on this, we submitted a proposal, and these were our first three specific aims, which I think are fairly traditional specific aims for most study. I think in aim 1, we were really looking at the question of strategies to deliver the family navigation intervention. And we added a fourth aim, which was to utilize implementation science to evaluate our implementation strategies. So it was, traditionally a hybrid type 1 effectiveness implementation trial. We worked on our conceptual model, and I have to say, when we started this and developed our conceptual model, we were real novices. I can't actually recall how we first learned about MOST, but I hadn't attended any training or the seminar. And this is what we came up with. And you can see we have the core components of the intervention, but we think of it as a sealed intervention. We really weren't manipulating how we trained, whether or not anyone received motivational interviewing or problem-solving training, or whether they received, whether the family navigators or family partners received different training around care coordination. What our experiment was really looking at was what are the components that fit in this space here, the delivery strategy. In terms of the rest of the conceptual model, we did have intervention targets, which we are measuring quantitatively, which have to do with improved capacity, parent capacity to pursue services, which sort of operationalized as both knowledge and sort of attitudes of mental health towards mental health services. We are looking at increased access to resources through something called the Family Resource Scale. And we gather information about structural barriers to care through Family Resource Scale, but also through measures we get as part of the electronic medical record. And our primary outcome, it's listed as the initiation of behavioral health services. That's how we submitted it. But this is the actual graph from our conceptual model from our grant application. But we've conceptualized it a little bit differently in the study. It's really the completion of the family stated goal. Because we found that families actually articulated their needs much more broadly than just the initiation of behavioral health services. So it included completion of, say, for example, a school evaluation or an evaluation for autism, or referral to in-home therapy. So we have a method of collecting data and looking at when the completion of the family goal occurs, and then also looking at engagement in services. Our distal outcomes, we hope that it will improve child symptoms, decrease impairment, and improve satisfaction with services. When we get to discussion, I would love feedback on thinking about if I were to do this again, should this conceptual model be more focused on the delivery strategies, and are the intervention targets, are they related to the intervention or to the delivery strategies? So I think we have it related to the intervention, but not specifically the delivery strategies. So what are these delivery strategies? So here's what we're studying. We're looking at the mode of delivery. So that would be usual, so meaning phone, or just sort of face-to-face, or technology assisted. And we utilized a platform called ActMD. And what it allows is for multiple stakeholders, so that could be family, maybe primary care center, school, daycare, to share a common platform and share documents and communicate via that platform. It had been used quite successfully by a team that runs an epilepsy center at the hospital where I was working when we first got this grant. So we thought that might be very helpful in terms of improving communication across sectors who can't access the patient medical record. Then we were looking at place of delivery, and that is clinic versus community. So traditionally, lay health workers who are based in some health centers don't go to the community. And in some places, they do their work almost exclusively in the community and aren't really integrated into primary care. So we wanted to understand how important was it for the family partner to be able to leave the walls of the health center to support families, say in school meetings or meeting them in the community. And the next had to do with symptom tracking. So routine symptom tracking occurs at children's annual well child visits when they complete a behavioral health screen. And in the enhanced symptom tracking, families were asked about their child's behavior and mental health symptoms every 3 months. So at 3, 6, 9, and 12 months, with the idea that would this enhanced symptom tracking allow us to sort of readjust or titrate services more appropriately as child's symptoms might change. And then the last was the visit schedule. So standardized meant that the family partner reached out on a specific schedule, and versus family directed, which was based on the family's needs. So it might be more intense for a period and then might not have any contact for many months. So those were the 4 delivery strategies which we were looking at. And then the implementation evaluation was mixed methods. We've done interviews with navigators. We will be doing them with key stakeholders, which will be folks at the health centers. And we also have pretty extensive EMR data to look at the exact the number of contacts, the type of issues that are being addressed, and time, and sort of just pattern of use. Our implementation evaluation is guided by the PRISM framework. I don't know if people are familiar with that. It's the practical, robust implementation and sustainability model. I'll talk a little bit more about that. Our hope is that we will be integrating findings from the implementation evaluation with results from the factorial experiment to really give us a pretty rich sense of which strategies worked best and how to think about the overall intervention. This is a slide that I took from a really recent article that I liked a lot. It is looking at the use of REAIM and the PRISM framework from a health equity lens. And PRISM is referred to as sort of the contextual expansion of REAIM. If people aren't familiar with REAIM, it's a really well-used and well-established implementation framework. And what I thought was helpful here was the health equity lens about things like when we think about reach, we're not just thinking about how many, but we're thinking about who. And is the who different, is our reach differential among, say, for example, in the health center that I worked, was it different among Vietnamese versus Hispanic families? It also is looking at any adaptations that might have happened to facilitate equity, and also the input of the community and the infrastructure in terms of promoting equity of health services in the site. So I want to sort of shift gears and talk about how we prepared for study implementation. And I first want to say this was a really pragmatic trial. The family partners were really integrated into the primary care setting. They weren't seen as research staff. They were seen as staff, really seen as part of the staff of the primary care unit. So there were both some challenges and some really nice synergies as a result of that. So in terms of preparing, study was a 2x2x2, I think I've got the right number of twos, factorial design, and this is what the different arms look like. And I have to say that the implementation of this study as a factorial design was really not any different than it would be for any experimental trial you were doing. While I think we at first thought, oh, 16 arms, oh my God. But it actually worked out, was not really a challenge. We approached randomization in this case using a minimization scheme. I think, I can't see who else is on the webinar, but I think that our co-investigator, Chris Sheldrick, is here, and he can speak more about the minimization scheme either now or at the end during questions. But one of the things we were concerned about was, given the number of arms and the number of people in each arm, was the balance of some of the characteristics of children that we thought could affect our outcomes, and wanting to be sure that we had some balance across the arms. So Chris created a really nice worksheet that the the research staff who was doing the enrollment would fill out that looked at parents' preferred language, was the family living in Boston or other surrounding areas, the goals, the insurance, gender, ethnicity, race, age, and age. So those, when that was entered, the button was pushed, and then the patient received, or the child or family received a study ID and a condition that was both numbered and named, like others we have used animals. And then it said the specific conditions that the family would receive. So this child the family partner could work with the family only in the clinic, would offer and enroll the family in ACT-MD. They could, they were going to have visits that were based on sort of family desire as opposed to routine check-ins, and they had enhanced symptom tracking.
Hi, Emily. I'll just interject that I think you described it really, really well, and I'm very happy to field questions at any point.
And then in thinking about family partner training and, well, actually training and supervision overall, I don't think this was really that different for doing a factorial study than it would be for any randomized trial. It was easy for the family partners to sort of understand what sort of the operationalization of each component. And they were pretty concrete. So you either did it or you didn't. It did, I think, so I don't think we had a issue with fidelity to the actual different study arms. I will talk a little bit about some of the other challenges we had. So family partners we had two family partners. One was Vietnamese and the other was Dominican and spoke Spanish. Neither had prior clinical training. They got training on common behavioral health issues in children, in the intervention content, so that would be motivational interviewing, problem solving approaches, the sort of basic ideas of care coordination, plus training in the implementation strategies and what each one meant. Community health workers or lay health workers often don't document in the electronic medical record. And as part of this being a very pragmatic trial, doing EMR documentation was also something that was new, and we did training on that, both how to document the work they were doing and how to use the electronic medical record to communicate with other staff at the health center. Research staff training was really pretty straightforward. I didn't put any bullets under here. It was, just standard research training. We did have, we had RAs that were separate from the site that were responsible for the initial kind of outreach to families, but the family partners did the consenting process as part of an in-person sort of initial meeting where they both did consent and initial goal setting. In terms of site buy-in, so the fact that there were all these arms didn't bother the site at all. I think the whole question about randomization in community settings is a general one, which is, are people, is the sort of cow condition, acceptable? Should everybody get the experimental condition? And in some way, the most structure made it more acceptable to community sites, because everybody was getting something. They were just getting a variety of something. And I think that, I don't think this would have been as well received if we said, well, some people are going to get the services of a family partner and others are not. In fact, I don't think we could have implemented that. So in this case, the ability to sort of say what we're really trying to understand is how to structure the family partner role to ensure the best possible outcomes, was really made it a much easier kind of sell or buy-in for the site. Intervention fidelity was, there again wasn't an issue about that, the idea that some families would get services, say, outside of the health center and others would not. People, the site was okay with that. One of the things that was important was site-based clinical supervision, because as I said, the family partners, while they were hired as research staff or hired under the grant, they really served as members of the primary care team at the health center. So how did people keep straight all of the work they were doing? When we started out, we had what we called action plans. For each family's stated goal, there was a series of steps that guided the family partner to kind of through the process. And it allowed us to sort of both track the sort of progress as well as the timing. And we developed action plans for sort of the most common goals. In this case, this is an example of one for an autism or other developmental evaluation, and also, which was pretty complex, whereas the one on the bottom had to do with referral and securing school-based therapy services. So we started recruiting. Everything was going pretty well. We were on target with our recruitment, and then COVID happened. And this made a huge difference for this study. So first, the health centers closed. They closed. They went to all remote. The main way we identified children for this study was generally through behavioral screening, which happened at well child visits, which were no longer. So it was not only the closures, and school was closed too, so kids couldn't get services, we couldn't get in touch with people, early intervention programs shut down. And I think also the community where the health center was really distressed. People had no food, they were stuck in their house. If they had COVID, there weren't the systems set up to get them food. So this all changed both the intervention and the role of the family partner, where for a period, their focus was on meeting the basic needs of the families that they were working with. As things returned to normal, we really moved a lot toward remote care and telehealth. And initially, that was sort of seen as a negative, but now I think we've learned that it's generally has some real strengths in terms of connection and ability to follow families, but it kind of messed up our study. So to look, so what happened? Well, we were on a kind of wild ride, and our four conditions we were looking at, two of them didn't really make sense anymore. So our usual versus technology, really, there wasn't no more usual. I mean, and usual wasn't usual anymore. Usual was, probably remote, and any way that we could contact families. And then we had the issue of place of delivery. So families couldn't go out to the community. I mean, family partners couldn't go out to the community. And in fact, no one was coming into the clinic either. And the only people that were coming in for a long time were essential personnel. So all of our behavioral health staff and family partners were working remotely. How we're going to deal with this in our analysis, I'm not exactly sure. I will be looking for help and advice. Kate helps us as a co-investigator on our team. So we're going to really have to think hard about how to understand this. The symptom tracking and visit schedule were really not affected. So where are we now? We began recruitment in 2019. We're pretty much done with recruitment now, maybe this week, 312 families. This is our consort diagram. We have good distribution, at least numbers across the arms. We haven't looked at the demographic characteristics within each arm yet. In terms of enrollment, where we see the numbers excluded, there were a lot of families we couldn't contact. I think they said they were interested, but they weren't. And that's okay, because I don't think we need to deliver this to people that don't need it. And the decline to participate was not related to research, which was great. There weren't a lot of families who, when they heard about the study, they said, It was more that they actually felt they didn't need the services of the family partner. These are just the child characteristics. So you can see that the average age, we were enrolling 3 to 12-year-olds. The average age was 7, a little more males than females, and quite a mix of race and ethnicity, and like 92% were covered by Medicaid. And these are parent characteristics. You can see we have a large number of families that speak other languages and that were born outside of the US. This is just an example of some of the goals that families identified. One of the most common was getting a school team evaluation to address either social, emotional, or learning needs at school, to get in-home therapy. We had a number of families that were seeking support around getting an evaluation for autism or their child's development. So those were kind of the main family goals that were identified. So just to conclude, our main challenges, COVID, really in terms of the experimental design. Again, we are going to have to think about what we do. The other was in terms of the conceptualization of our primary outcome. The wait list for some services was extensive, like months, like maybe like 6 months. When we thought about connection to services, we conceptualized that as having a completed referral and having the family in the list for the service that they desired. We had some challenges around abstracting data from the EMR that Chris could talk to more directly. We thought we had a pretty good system, but in fact, it is requiring a fair amount of going back to the actual EMR to abstract the data. We also have lots of families where there were siblings. So we were enrolled an index child, and then the family said, well, I need help for this child also. So our primary analysis will be based on unique children, but we'll be looking at the, what differences we might see in families where there was a sibling enrolled. And I think the last two were that the changing landscape in primary care. When we started, we had just these 2 family partners and 1 behavioral health clinician. Since that time, we now have 5 family partners and 3 behavioral health clinicians, so that the context in which they're working in is quite different. And our conceptualization of there being a fixed intervention period and follow-up, which is necessary for, I think, grant purposes, doesn't really match with how things happen in primary care. But I think it just sort of, it became a challenge in terms of families that wanted to work with the family partner longer and how to address that. We are about to begin the analysis of primary outcomes and the implementation analysis. And I'm actually really excited about the whole process of, sort of prioritization and how you think about optimization. It's something really new to us. And we are hoping it will be a really rich discussion of how to think about the work that's happened over these now 5 years. So thank you, and have any questions?
Well, I am in the process of dropping a link in the chat. So Emily, I think you know this, but we tout you in this project really as being the first, if not one of the first, study using intervention optimization to look at implementation kind of strategies. And so this is an area that we think is wide open and ripe for most. So Linda and I wrote a paper with some ideas about how they could be integrated. And so put that in the chat. And the study that Emily presented is one of the examples that we kind of highlight there. So I want to say Chris is here, Nina's here, and other members of your team, Emily. So if you want to open it up or however you'd like to do it.
Yeah, well, first of all, I'd like to just recognize the members of the team. We have a great team. We have worked really hard to think through sort of on the ground, the kind of challenges that have come up with the study. I want to thank Chris and our project managers and our new staff at Brown who will be helping with the data analysis, and just ask if they have any comments or points that they want to just highlight in terms of their involvement in the study.
I'll just kind of chime in and say that, as always, Emily, I appreciated your talk. And I think I would agree that the challenges that we faced are not specifically really related to the MOST design. I think COVID proved to be more challenging than the MOST design, which is good news for the MOST design, bad news for COVID. If I had any caveat there, I will say that like things that seem like details, like small details when writing the grant, like the allocation procedures for randomization, are actually kind of a big deal. So I could see that being a place where teams would really want to either make sure they have the right expertise and or a place to kind of develop tools to make this a little bit easier down the road, given how many conditions there are. And when there was a link that was put in the chat, and it seems to me like my impression was that when we wrote that paper, we did a whole bunch of simulations that were specific to our study. So we were pretty confident in what we did for our study. But having done those, I was not at all comfortable trying to say that there was any kind of real generalized solution for how to attain balance, because it kind of depends on your patient population and what you're trying to balance on and what those proportions are. And it can sort of be particular to that setting. So just having those kinds of things in mind, that there are maybe hurdles to get over that might be a little bit harder here than otherwise, but once you do, quite manageable. And the most important thing is, I think, really acceptable to patients and acceptable to clinicians, the way it was framed.
Yeah, I wonder if I can just point out, so what happened to you losing 2 factors in a factorial experiment? That is something that many people who are maybe considering a factorial optimization trial for the first time would think is a horrible nightmare. And it's, you know, it's wasn't your first choice. I'm sure that you would have preferred that didn't happen. But I want to point out that that did not kill your experiment. I think that that's a really important point. The factorial experiments are a lot more robust than it probably seems if you're not familiar with them. So what you guys are going to do when you do the data analysis, you'll just collapse over those factors. And it's, you know, you're going to have so that's going to move some variability into the error term that you would have been able to model otherwise. So you'll lose a little power, but that's it. And so you're still going to be able to do a lot of really interesting analyses. So factorial experiments they're not fragile things. They're hard to kill.
So Linda, just on that question, so what we don't have is data on everybody who, well, some people did get, were assigned to an arm and got the conditions as we specified.
Mm-hmm.
And then there was a period that they didn't. So would we do, like I understand the collapsing, but would we try and look at the times when, say, pre-COVID and when things sort of returned to normal as kind of a sub-analysis, even though it wasn't based on our, you know, the power calculation that we had?
You potentially could. You know, it's hard to talk about this sort of thing in the abstract. We'd have to talk about exactly what you want to learn to talk about exactly what analyses you'd want to do, I think. But for your main outcome analyses, I think you're going to want to do the collapsing thing that I talked about. And you potentially could, depending on what else you have in the model, you potentially could include a covariate to try to model some of the variant, the unplanned variability there, because you don't have balance on the factors you're collapsing over. If you did, you wouldn't be collapsing there. But I don't think that that's going to be. I mean, ultimately, you're still going to be able to take a good look at those remaining two components, and then yes, you'll have to do. You'll probably want to do some other analyses to try and get at what you originally wanted to get at, but those are going to be less satisfying, I think, just by the nature of things. But it's just really important. I hope the audience, that this is one of the take homes for the audience, that unexpected events can occur while you're conducting an optimization trial. I mean, COVID is probably one of the bigger unexpected events that, you know, we could think of. Most of the time that will not kill the experiment. You will still be able to get, you may not be able to get everything you originally had set out for, but you'll still be able to get interesting results, and you'll still be glad you did a factorial experiment.
So one of the things we've been discussing as a team is sort of when we get to thinking about how to kind of decide on what the optimized intervention or optimized delivery strategy would be, is how do we balance or take into account the fact that the intervention may cost more or require more intensity, or a condition may work differently for one racial or ethnic group versus another. So for example, at this health center, engagement of the Vietnamese families in behavioral health services has been much more of a challenge than, say, among the Latinx and Black families. And if we wanted to say it's important to us that this group, you know, sort of has equal benefit, how, I mean, it's just something we're thinking about. How do we fit that in? Or how do we think about that?
You know, it's so interesting you're asking that question, Emily. And is just Jillian Strayhorn, is she not here with us today? But I wish she were, because she and I and a health economist, Dave Van Ness, we just submitted a manuscript to the journal Prevention Science that talks about how, just some initial ideas, because it's a complicated topic, about how you would incorporate equity considerations in optimization. So we talk about optimization as being a strategic balance of effectiveness on the one hand versus other considerations like affordability, scalability, and efficiency on the other hand. But you also could have equity in the mix there. That could be one of the, so now instead of balancing these 4 things, you're balancing 5 things. The conclusion we came to is that, well, we outlined an approach for doing that under some circumstances and kind of the beginnings of thinking through how to do it under more general circumstances. Like, for example, we were unable to get as far as a situation where it's a multi-level model because we just, we didn't want to think through every single thing before we publish the paper, because that's the way. But anyway, so I'd be happy to share that with you if you're interested. It's not, I'm offering this to Emily, not to everyone else on this, because it's not quite ready for prime time yet. We want to get the reviews back before we do too much more with it. But I know it's potentially directly relevant to your work, Emily. So if you're interested, I'd be happy to share it with you. Or when the time comes that you're interested,
yeah. That would be great. I mean, I think we're not quite there. We're sort of getting our data ready to be able to analyze and look at.
Yeah.
But it is something that I think as a team we've thought a lot about. That maybe the intervention that has the greatest good for the most people isn't what we're looking for. So,
yes.
How do we think about it differently?
No, that's absolutely the direction we were going. And Dave Van Ness, a health economist, fortunately for us, has thought a lot about the health economics of equity. So he was able, I think, to help us get a good start on this. And yes, sometimes a trade-off there is between kind of overall benefit versus equity. Just because you have the largest overall benefit, it doesn't mean you've achieved the best you can in terms of equity. And similarly, just because you've achieved the best you can in equity, it doesn't necessarily mean that that's the largest overall benefit. So these are painful trade-offs sometimes. And sometimes the trade-off is if you've got a certain willingness, a certain upper limit on willingness to pay, then the trade-off can be a pretty stark trade-off between equity and kind of an overall benefit. If you're willing to increase willingness to pay, then sometimes you can accomplish both under some circumstances. But I think to me, and we were just working with artificial data, so it would be so interesting, to work with you on your data and get a sense of, what would happen in an empirical data set. But it was pretty easy to show that with artificial data, that there are times that to achieve both equity and an overall positive health benefit is just going to take more money. Yeah. So I think as a society, I predict we're going to have to pay for equity, which to me doesn't seem inappropriate, but it's just, I think it's important to recognize that.
So I think it's going to be, I want to be the fly on the wall when Chris Sheldrick and Dave Van Ness talk about this. We've definitely had this. So just in the last couple minutes, want to say if there are any lingering questions, feel free. But
I have a question.
okay, there's 2 minutes. Go ahead.
Okay. May I don't want to cut other people off.
Go ahead.
Emily, I want to ask you something. Kate and I have a moonshot goal, which is to make intervention optimization the standard by the year 2030. And some of you who are on this webinar have heard me say this before. I've been pretty open about it. And my question to you is, do you think that's feasible? Do you think we're getting to a point where, and by the standard, I mean, if somebody submits a grant proposal, it's kind of expected in the intervention development area, it's kind of expected that they would use intervention optimization as opposed to just going straight to the classical treatment package approach.
It depends on how willing funders are to fund an optimization trial. I think conceptually, it makes a lot of sense. I mean, because what do people do now? They do underpowered pilot trials to show, and there's huge, I think, misconceptions at study sections about what you're supposed to get from a pilot study. It's like, they didn't show efficacy. Well, it's not meant to show efficacy, but the study section still wants that. So in some ways, moving away toward saying your step shouldn't be a pilot trial, your first step should be an optimization trial, makes a lot more sense to me. But, got to get the money. And so I think it's money and training, and also for reviewers. I think the reviewers need to understand how to look at an optimization trial and not, and have sort of clear sense of how do I judge the value of this.
Yeah.
I'll just chime in there too. Like it reminds me of for a while one of the NASA kind of slogans when they were trying to go to Mars for the first time was like better, faster, cheaper. And I think most is better in a whole lot of ways. I think for a lot of teams, it's not necessarily faster or cheaper, at least cheaper in terms of time, in terms of the support that's required, because it can seem, and I think a lot of it's perception. Like I think it can seem overwhelming to people, the number of conditions or whatever else. And so I'll just conclude and say that this makes me think that it could be valuable to publish just saying, hey, like, look, we did it. We assigned people to conditions. It wasn't a big deal. Like, you can do this. Like, I think sometimes we forget about the low hanging fruit as we're charging forward and forget to show that like the early steps are actually quite possible.
Yeah.
You can do this. What a good slogan to end this on.
Yes.
Thank you. Yeah. Thanks, Chris. Emily, thank you very much for your time and sharing. Thank you all for being here. We do have one more webinar for the spring semester, season, series, whatever. You can find it on our website or in the chat.
And we will be back in the fall after that one.
Yeah.
But be sure to tune into the next one.
All right. Thank you all.
Thanks again, Emily.
Thank you.
Chris, it's great. Bye-bye.